Hi, I'm Professor Molly, and I am going to discuss the insulin types. And this is part 4 of the diabetes lecture series. So first, I want to make sure you guys remember listening to what I said about the basal and bolus secretion of our normal pancreas. Well, that's how insulin is working. So when we are giving insulin injections, we are mimicking the basal and bolus amount of insulin our body typically is supposed to respond to remove the glucose from our bloodstream. And that is to mimic the natural function of our pancreas. So it is really important to know that when you are giving rapid and short-acting insulins, it is mimicking the bolus function of our pancreas. When you give intermittent and long-acting insulin, it is mimicking the basal function of our pancreas. Now, we're going to talk about the rapid and short acting first. The rapid and short acting is acting like our bolus insulin. So when we eat something or ingest food, we need to go get the glucose immediately out of the system. And so this is going to act fast, and it's going to have a faster onset. The peaks are going to be faster and the durations are going to be shorter because, again, it's acting like that bolus insulin secretion of our pancreas. Rapid is the fastest acting. And the most important thing you need to know about this is that you have to eat within 15 minutes. So most of the time you will see the sliding scales when you're performing your AccuChecks in the hospital or in clinical. You will do an AccuCheck, AC and HS, or every 6 hours or whenever it's ordered. And typically you're going to have a rapid acting insulin as the coverage for that blood glucose. It's going to give you a range, and you're going to usually give either it's going to be the Lispro or the Aspart, which is also known as Novolog. It depends on what insulin your hospital carries is the one that's going to be on your formula. So this is rapid acting. But before you give it, you check your blood sugar. Do they have food? Have they eaten? And do they have their meal tray in front of them? That is one of the most important things because this is acting and mimicking, again, the normal secretion right after you eat. So the peak is going to be about 30 minutes. And it's really important to make sure they have food because then if they don't, they're going to become or could become hypoglycemic. Now the duration is shorter. It's going to be around 3 to 5 hours. The short acting is a little bit safer. It's actually a little bit easier to incorporate into most people's lifestyle because it is not going to onset until usually around 30 to 45 minutes. And so it gives you a little bit more time to get the food and to get your meal tray in front of you. Again, it's still going to act faster, but it has got a slower onset, 30 to 45 minutes. And the peak is going to be around 2 to 3 hours. So it's going to have a little bit longer peak and a little bit longer duration. So you have to know it's going to stay in your system. Anytime you give insulin, you have to remember that this is going to stay in their system. So every time you give something on top of it, insulin, or they're going to eat, you need to still remember that they have circulating insulin in their blood sugar based on the type of insulin you've given them. Now, one more really important thing to know, and this is probably going to be on a lot of tests. I would not be surprised if you see this. You're going to see it in the hospital. Regular insulin, it's a clear insulin, is the only insulin you can give IV. It's the only one. That's it. You can't give any other ones IV. The other ones are going to be sub-Q. And you're going to see this. And what you should know for being regular is there's going to be an R at the end. So Humulin R, Novolin R. That R is going to help you distinguish that it's a regular insulin. Now, if we move into the intermediate and longer acting, this is going to mimic the basal rate of our insulin. So it's going to act longer, like our normal secretion of our pancreas. And so this is going to be in an intermediate or longer acting. The intermediate, they're cloudy and they have an N after it. So NPH is your intermediate acting insulins. And there's an N at the end of Humulin and Novolin. The onset is going to be slower. It's going to be about 1.5 to 4 hours, and it is usually used alone, or they can mix it. And I'm going to go into the next slide where we mix insulins and why we do that, because we're trying to mimic our normal basal and bolus rate. And so we're going to mix typically like a shorter or rapid acting with this intermediate, so it kind of lasts throughout the day. And so a lot of times type 1 diabetics will use this intermittent insulin for their management. Now, it's really important to monitor for hypoglycemia because it has a longer peak range, about 4 to 12 hours. So you have to make sure that they understand the signs and symptoms of hypoglycemia, and the duration is going to last longer, up to about 18 hours. Now, the longer acting is safer for most people, and you're going to see most patients on longer acting. And this is why, because it has no really pronounced peak. And this is going to help because it reduces the effects of hypoglycemia. And so it's really kind of better for most older adults. They typically take this once a day, and there is different types. Lantus, Levemir are some typical ones. People go home with this and they sell them and give them in pens that they don't have to inject and pull out of a vial that we have to do in the hospital. So it makes the dosage a lot more easier for these patients. And I'll have a picture of that in the next slide. So it releases continuously during the day. It mimics your basal rate of your pancreas. And again, there's really no pronounced peak time. So it's less, you have less pronounced or problems with hypoglycemia. And it lasts up to 24 hours. So typically this is a really good one for most diabetics and type 2 diabetics for that matter. All right, now the important nursing tips to know is that this is always given subcutaneously, and it's either a 45 to a 90-degree angle of your needle. So refer to your sub-Q injections when you're giving this insulin. Now, you can give regular insulin IV. That's the only one. Remember that caveat? Now, if you are giving this and it goes into the muscle, then it can cause delayed absorption, and that can cause hypoglycemia for the patient. Now, also, you want to make sure you rotate at least the sites to 1 inch to an inch apart. So, and keep your injection away from the umbilicus, so your belly button area, and you want to be about 2 inches away. So typically you're going to pick either the left or the right, upper or lower quadrant, and or another common site is the back of the arms. And most people that are giving it to themselves at home they like to use the outside and the back of their thighs. So they will pick that as well, that site. So NPH only lasts typically about a half a day. So most people, again, remember we said the duration for that was around the 12 hours. So they will give themselves usually an AM and PM dose of this, and that is a BID dose. Now, longer acting is in the picture here, and this is typically given once a day. Detromir can be given BID, but Lantus and usually Levemir is given once a day. And you never want to dilute it or mix it with other insulin. So longer acting is not mixable. And in this one, this is a home pen that is being used, and you can see that you're not able to mix it because it's a single use only. And you have a dial of how much insulin you're going to do on that right side. And then you'll put a little needle that you will take off and put in a sharps container every time you give yourself a shot on the other side. So this is what an insulin pen looks like. Okay, now I just want to go over, if you are happen to studying how to mix insulin or why we mix insulin. The thing is that sometimes you have to do this, and we do that to decrease the number of injections that the patient has to take. And again, it's mixing in one syringe how the natural body is mimicking the basal and bolus secretion of insulin. And so we always draw up air first when we put our syringes in, and then we draw the meds up. So in this order, there's a little simple way to remember it. A lot of people don't know who Nancy Reagan is. That's old school like me. So I put in Nicole Richie, RN. So you draw it up as Nancy Reagan, RN, or Nicole Richie, RN. So you always never draw up cloudy before clear, because we don't want to mix any cloudy insulin in our clear insulin. So that's when we get to the draw, we draw up the clear first, and then you draw up the cloudy. So you'll put the air in the NPH, which is cloudy, then you'll put the air in the amount of air you're going to draw up for regular, and then in the syringe, you're going to draw up the exact amount of regular insulin you need. Now, it's really important because you can't keep pushing and pulling. As soon as you get the amount of regular insulin and you stick the needle in the NPH, then whatever your dose is, you have to be able to pull out the exact amount of NPH, because you can't push that back up into the NPH either. So you got to be really precise when you are drawing up and mixing insulins, because if you get the air bubble and you know how you push it back up and you pull it back out, you can't do this with this one. You have to be very precise. So again, if you mess up, you have to take the whole syringe out and start over again. So that's why this is a little tedious, but this is why we do it. So a lot of times there is pre-mixed syringes, which is nice because then you don't have to mix this up at the hospital. Again, pharmacy may be the one helping you do this, but this is the reason and the rationale for why we mix insulin.